Thanks again for joining us. Today we've had some incredible speakers, and we have our last speaker here. I'm excited to introduce Dr. Chester Ho. He's going to be speaking about transitions in care after spinal cord injury. So Chester Ho is a physiatrist and is the medical director at the Glen Rose Rehab Hospital in Edmonton. Please take it away, Chester. Thanks for coming.
Thanks, Casey. It's really my pleasure to be here today. And when we started this session, I remember Julie stating that this was sponsored by the Concentric Project. So I think a number of you may be wondering, what on earth is that Concentric Project? So I'm going to tell you about it. So hopefully within the next 35 to 40 minutes, I'll tell you more about that. And so basically, my talk is about, whoops, okay, um, transitions in care. And so my objectives are that, first of all, I want to talk to you about what transitions in care means and how that applies to the journey of persons with spinal cord injury. And then I'll talk about the Concentric Project and share our findings so far and how the findings can actually improve the transitions in care experiences of persons with spinal cord injury. So what on earth is transitions in care? If we look at the definition by the Canadian Institutes of Health Research, basically transitions in care refer to when transfer of responsibility and accountability for some or all aspects of patient care occurs among providers, institutions, and or sectors. So that means really a whole number of different environments, not just in the healthcare settings. So I want to emphasize that. And so, as you can imagine, if the person's condition is more complex, then there are more transitions in care. So let me give you this concrete example here, right? So let's say after an acute traumatic spinal cord injury, typically that person would be taken to the emergency department. And then, right, um, likely they'll be going to the operating room. And then from the operating room, that person will go to intensive care later on. And then from intensive care, days later, sometimes weeks later, they'll go to the surgical care unit. And then from the surgical care unit, they will be transferred to the inpatient rehab program. And then from the inpatient rehab program, once they're done, they'll be going back to the community. So we can see that this can just occur within several months of that person's life. So with each transition, you're dealing with different care providers. You're dealing with different physicians, nurses, allied health professionals, housekeeping people. It's bewildering, isn't it? Because sometimes people pass on the information quite well, but sometimes they may focus on certain aspects, but other aspects may not be so well, transitioned over to the next point of care. So you can see that this is really quite an issue. Now, I remember when I first started my position here in Alberta, I was told that after we're done with rehab, we transition our care for our patients back to the primary care provider. And I always was like scratching my head, thinking, okay, how do we do that? Do we simply send them a discharge summary? And is that how we transition the care over? And I'm like, does the primary care provider have all of the resources and the training and knowledge, right, to take care of people? And also, as we know, primary care is only one piece of the puzzle. And there are lots of other things that we need to think about, community organizations and partners, etc. How do we actually transition them? So I was really quite puzzled. And then I was hearing from my patients, some of the patients said that when they left the rehab hospital, they felt like they fell off a cliff. So that really hit me like, a brick. And so I thought that we should do something about that. Plus, also, it's not just the patients. When I talk to my colleagues in the community, they told me that, you know what, if only we knew more about, the patients coming back to our area, if we only had better handover, if we only were told more about that patient, we could have done a better job. So that really got me thinking as to how we should do that better. So then 2019 came, and there was actually an opportunity by the Canadian Institutes of Health Research. They recognized that transitions in care are really a big deal in healthcare. So they actually had a special competition for people to apply for grants to support projects that would study transitions in care. So I got together with a number of partners around the province and said, listen, should we be applying for grants, to look at this? And the response was like, yes, we really need to do so. And that's why we applied for the grant. And we call that Connecting and Coordinating an Enhanced Network for Transitions in Care, or Concentric project. And we're lucky that we actually got funded in 2019. Now, that was like 6.5 years ago, and you think that's a long time, but remember that right after we got the grant is COVID. And so we really were delayed by COVID for quite a while, but we still were able to finish the project. So that was wonderful. Anyway, so the mission of the project was to design, implement, and evaluate an improved evidence-based and standardized provincial model of care with clear transition strategies for persons with spinal cord injury. And here we have our QR code. You can actually use this QR code to go to our website or just type in concentricproject.com. And if you actually type in concentric SCI on the Google search, it's the first one that pops up. So please take a look because that website is really very informative. And so I just want to take this opportunity to introduce our leadership team and also some of our really important team members here. So we have a steering committee that included researchers, clinicians, as well as statisticians and students and coordinator from all over the province. And we also have a number of change champions who basically are a number of individuals from both the community and also from different healthcare settings who are embedded in the healthcare setting. So they are also clinicians who basically were helping us or have been helping us to make the changes in the healthcare system as embedded people. And we'll come back to that in a moment because their roles are incredibly important. And you may recognize some of them here as well. So how did we do it? Basically, the approach was that we took this community-based participatory research approach. So everybody was important. And when we say community, we're not just referring to community as in like outside of the hospital. We're talking about the SCI community. So that means that that could mean healthcare providers as well as people with SCI, their family members, and also people from the community and organizations like Spinal Cord Injury Alberta, who's been an incredible partner throughout this journey. So basically, lots of different partners are involved. I'll show you more later on. And this is a pilot project. So we have 4 pilot sites, and I'll talk to you more about which sites they are in a moment. Plus also SCI Alberta. As I said, they really have been an incredible partner. So there are 3 stages to this project. The first stage was to analyze what the current situation was. with our partners all over the province to really understand the problems. Because oftentimes we have our assumptions, right, as to what things are not working. But actually, no, we had to do a due diligence and really understand this properly. Hearing that from not just healthcare providers, but also from people with lived experience and their family members, etc., to really understand what's wrong with the current situation, as well as what's working well as well. And then the second phase was that once we actually got the analysis done from stage one, we would then have this co-creation of evidence-based and standardized solutions that we all agree on. And with that, we'll go to stage three, which is right where we are, is model implementation and evaluation. So I'm just going to show you this slide here, just to show you who we have really engaged throughout this process. I'm not expecting that you'll be seeing all of the small text here, but this is just to show you that we considered multiple settings, all the way from inpatient to discharge, to post-discharge, and also readmission to the hospital, as in the case for some people. And we looked at, lots of different structures like home care, primary health care, ambulatory, outpatient, and also community-based, environments. And so with that, we identify a large number of partners that would be involved in this work. And so this slide here shows you who they were. So we had a number of people with lived experience, their family members, and also community organization partners, government representatives, clinicians, and researchers. So everybody was really involved. And the four pilot sites were Slave Lake, Edmonton, Lethbridge, and Calgary. So you may know that Slave Lake oftentimes has patients in the Edmonton, a rehab program at the Glenrose. And similarly, people from Lethbridge may be going to Calgary for their Foothills Medical Center rehab program. That's why we pair them up like that as two pairs, so that we can learn from them. And also, you can see that we deliberately chose Slave Lake because it's a truly rural area, whereas Lethbridge is more like a smaller city. So we can have different learnings from the different settings. And then you see that we had a number of working groups throughout all of our different journeys. And so with that, we basically came together and agreed on 5 key themes for successful transitions in care. I apologize that in the interest of time, I skipped all of the details in the middle, but I jumped straight to the conclusions here, to the recommendations, which I would love to share with you in a moment. And you see that basically for our 5 themes, they are person-centered care planning, communication and collaboration, focus on healing and recovery, peer support and education, and resource accessibility. So with this, we find that these are the 5 key themes that would really, help us be successful with our transitions in care. And you see that we have these themes and recommendations again on the website, and here it is, our QR code, and also our concentricproject.com address. And you see that what we are saying here is that these are the what's. We're not telling people how to do so, because we recognize that for each location, for each center, for each group of individuals, they have their own um, you know situations and also context. So we recognize that, and we're not going to tell people what to do. Instead, we're just saying to them that these are the things that will make you successful. So how you go about that will be your own business to suit your own context. So let's take a look at these 5 themes and what we're recommending here. So for person-centered care planning, basically the objective was to ensure that persons with SCI and relevant SCI partners are consistently engaged in the development of and have access to an updated person-centered multidisciplinary care plan across the care continuum. So there are a couple of things that I want to emphasize here. Um, the first thing was that historically speaking, a lot of care plans were, focusing on the engagement of the nursing team, and sometimes with also allied health, but they did not typically engage people with lived experience and also their families. So here we really want to focus on the engagement of persons with lived experience and also their family members as well. And so that's one thing. The other thing is across the care continuum, because oftentimes, right, we would design a care plan that's actually appropriate for that setting. But what we're saying here is that we need to have a care plan that the person with SCI would own and then take it to the next phase in their journey. Let's say if they go back to the community, then this care plan can be modified and used by the primary care team or by the community rehab team or by whoever they actually choose to partner with. So, with that in mind, the recommendations are that we ensure care providers engage persons with SCI and the family in developing and updating a person-centered multidisciplinary care plan that includes relevant health information, goals, and available SCI resources. The second recommendation was to provide information on SCI resources that are tailored to the need of each person with SCI in the multidisciplinary care plan, because we can easily just throw in lots of generic information and resources, but that could be overwhelming. So we want that to be more customized to that individual. The third recommendation is to ensure that care plans are accessible to persons with SCI and all relevant partners throughout the care continuum. And I think that we have a really great opportunity here as well, especially because we have now a provincial electronic medical record. And I know that it's not perfect, and there are still things that we're working through, to make that system better, but still, it's already much better than before. Now, the fourth recommendation is to establish clear post-discharge follow-up arrangements for persons with SCI with scheduled visits to SCI specialized clinics, for instance, the physiatry clinics at specific intervals. You know, these things actually seem to be quite common sense driven, right? But you'll be surprised by actually how they may not have been done in the past, and also how even sometimes making a small change to something like this would actually take a lot of effort. And so I hope that these actually resonate with you. And I'm not now going to move on to the second theme. Oh, before I do that, sorry, I want to share with you a quote from a person with spinal cord injury. This person said they have to listen to their clients. They have to follow with their clients, not them coming in there and start guessing. Oh, it could be this, it could be that. These were actual quotes from our study participants. And so now let's move on to the second theme, which is communication and collaboration. And the objective is to ensure persons with SCI and relevant SCI partners in the community and hospital settings are connected and able to maintain two-way communication as needed throughout the care continuum. We oftentimes hear from our partners in the community that they did not know how to get back to people or to reach out to people in the SCI centers. And so I think that this bidirectional communication is really critical. So the recommendations are, number one, develop clear communication processes, protocols, or channels to facilitate communication, connection, and collaboration between persons with SCI, their family, community partners, and care team in spinal cord injury centers. Number two, to promote ongoing two-way communication between SCI specialists and the community care team of persons with SCI after discharge. Number three, identify and establish connection with relevant SCI partners across the care continuum, particularly those who will serve as main contacts for persons with SCI at the community level. Then four, create opportunities or platform for SCI partners to collaborate, share knowledge and network with the goal of creating and maintaining a community of practice across the uh, acute care, inpatient, outpatient, and community settings. So what we are talking about here, again, it seems so intuitive, but these were the things that really popped out in our research findings. And so I want to focus on a couple of things. And I already mentioned about the two-way communication. And the other thing that was really brought up was that, right, people would love to have a community of practice. And they're talking about a community of practice that's not just for the clinicians or providers, but for all SCI partners. So that would include people with lived experience with SCI as well as their families, and also with community organizations and community, healthcare providers as well as hospital-based providers, etc. And so I think that was really a clear message that we heard. And so, we need to think about that because sometimes with communities of practice, we may be thinking more about, clinicians. But I think that from this, we're hearing that people really crave for that connection between the various partners beyond the healthcare setting. Okay, so that's the second theme. And now this is a quote from an occupational therapist from a rural setting, who's also one of our research participants. I think when you start looking big picture, right from the beginning, you pull in all the right stakeholders, and that takes a little bit of extra work. But if you do it, it's well worth the investment. It just creates a better coordination and it's more timely. We actually look like we know what we are, doing together. So I think that was really quite some really good insight from a colleague in Ally Health from the rural area. Okay, let's go to our third theme, focus on healing and recovery. So the objective is to make healing and recovery key pillars of the rehab process for persons with SCI as early as from inpatient rehabilitation. Now, let's look at the recommendations for some more specific things that people have in mind. The first was care providers and persons with SCI to co-determine and agree on realistic recovery goals based on the prognosis and expectations of the persons with SCI at every stage of the care continuum. This is actually quite a loaded recommendation because it basically talks about how we need to work together between providers and persons with SCI so that we come to a consensus on what's realistic for the recovery. So we don't overestimate or underestimate people's recovery potential. And also it talks about how we really understand what the prognosis may be for that person. And as we know, over the last 20 years, there have been lots of research done about the prognostication for people with SCI. What we had known before may not be true anymore because I remember 20 odd years ago when I first started, right? If we look at the prognosis of people with the so-called quote unquote complete injury, then what we know now is very different. And so if we still kind of go by what we had known 20 something years ago on the prognosis of the individuals with such an injury, then we may not be actually doing that person a favor, or in fact doing them a disservice as to how we do the care planning and rehab plan. So I think that's what we're hearing loud and clear from our community, from our SCI community. So that's the first one. The second one is to embed and integrate healing and recovery programs or principles into standard rehab protocols or therapy sessions, drawing from current evidence on SCI prognosis. Now, I talked about the prognosis part already, but I want to emphasize more about what people really meant by healing and recovery. Because what we're hearing is that people are not just talking about their physical healing and recovery, they're talking about their spiritual healing and recovery, as well as their mental well being, and also their community reintegration. So it's a much more holistic approach than what they, seem to be receiving right now. So I think that we need to really think about this and um, and see how we can integrate the healing and recovery, um, you know, perspectives from people with SCI. The third recommendation is to create opportunities for SCI partners to learn, discuss, and share current knowledge on SCI prognosis and the healing expectations of persons with SCI. The fourth one is to integrate current services focus on healing and recovery into what we do. So things like adapted exercise programs um, that are really quite gaining lots of momentum and lots of attention now, especially in the community. People are saying that let's actually see how we can integrate these things into the rehab programs, including also recreation and sports programs. And sometimes I think that what we're hearing is that people say that, we think, okay, this is what we do on the inpatient rehab side. This is what, you may do it in the community, so it's not our business. But what people really want us to think about is how to integrate all of these into a package that's more holistic. So I think that we need to have a lot of discussions on this one. So this is a quote from a person with SCI, and he basically said, well, everyone said it was going to be great in rehab, and then it just turned out to be pretty much a wheelchair facility. Not too much rehab happened there. It's more of an adaptation hospital than a rehab hospital. Now, I have to say that when I first saw this quote, it, it was very difficult for me personally because, I was really shocked to see this, but I had to really have some self-reflection. And I had to eat my humble pie and think long and hard about this. And then I start to understand what this person was going through and what we really have to do something about. So I hope that, when you read this quote as well, that, you also may have the opportunity to have some self-reflection as well. Okay, now the fourth theme is about peer support and education. This one was really, really interesting because over the last few years, when I went to international meetings, peer support was really all the rage. Everyone's talking about peer support and how we should do this and how we can deliver, our services with different types of peer support. It's so interesting. Now, the objective for this is to improve SCI knowledge and self-management skills for persons with SCI through peer support, education, and regular relevant knowledge updates. So the recommendations are number one, review and modify as appropriate existing peer support programs for improving self-management skills of persons with SCI. Number two, provide training to peers on how to formally teach other peers on self-management, taking into account the variations in peer experiences. I mean, we are not born teachers, right? I'm not saying this is teaching people, but still, we all need training. So basically, this point is just to say that, right? If people are wanting to be peer support, let's actually provide a training to help people to do that properly. Number three, organize education days and series just like this one in collaboration with persons with SCI and partners to provide updated knowledge about SCI and SCI care. And so I'm so glad to be here today, in this event. And number four, provide education for partners, including persons with SCI, on how to access SCI specific resources throughout the care continuum. And I do want to recognize that, when we think about peer support and, you know, um, actually, uh, there are lots of things that we may not be doing that other countries are doing. So, for instance, when I talk to my colleagues in Sweden at the Karolinska Institute, they have fully embraced, having peers as part of the care team. And so peers actually co-treat with physiotherapists as to how people can do things like transfer training, etc. And so I asked the question, right? I asked Thomas, the manager there, I said, Thomas, wasn't there any concern that people would have, when they co-treat like that? And Thomas said, no, actually, people really get along well, and it was a wonderful model, and they work so well together. So I think there's a lot to be learned from there. So I hope that we can, continue to learn from other people to see what we can do, in addition to what we do well already, because I know that we do very well with certain aspects of peer support already. Okay, so this is a quote from a female with SCI. As much as the doctors and nurses can be amazing and can provide you with all the education that they are aware of, they're not in your position. They will never fully understand being in your position. The only people who can do that are your peers, and I think that peer support would be hugely beneficial. Okay, so this is our fifth and last theme, and that's resource accessibility. The objective is to streamline ways for persons with SCI and partners to identify and access appropriate resources. And so the recommendations are to create a centralized resource list relevant to persons with SCI and other SCI partners, especially those relevant to individuals in Alberta. And number two is to simplify and to provide suitable guides or templates on the application process for resources, particularly funding with relevant partners. And I'm really grateful that for this particular theme, actually, our wonderful partner in SCI Alberta has been really leading this work. So I'm very grateful for them for doing so. And so this is a quote from a psychologist. And if you didn't work in this environment, you wouldn't know what resources exist for the spinal cord injury population. But honestly, I worry because I have had this feedback from patients before. They get so much information when they are at inpatient, and they can only absorb so much. So it's really about having the right information at the right place and at the right time, and have the ability to have the information to be repeated, to be given, at different times, right, for reinforcement. So we have now gone through the 5 themes and recommendations. On this slide, I just want to share with you something that also happened during our project. Over the last few years, Health Standards Organization, which is part of Accreditation Canada, they're kind of like the technical arm for accreditation. They basically determine, look at the evidence and then see what should be recommended, in the accreditation process. And they actually were going through this for spinal cord injury. So last year or the year before, I can't remember, but very recently, they came out with the standards, the new standards for spinal cord injury, that the new accreditation program for spinal cord injury is based on. And so if we actually do a crosswalk between our recommendations and also the HSO standards, we actually found lots of great alignments. So I'm not going to go through all of them, but I'll just highlight a couple of them. So for our recommendation about engaging persons with SCI and their family in developing, right, a person-centered multidisciplinary care plan. Guess what? For the standard 4.1 in the HSO standard, they talk about teams co-design and continuously update the individualized care plan of the person living with SCI to ensure continuity throughout the SCI rehabilitation continuum of care. So we started doing our work separately from the HSO team, and we came to the same conclusion here. So I think that really is great kind of, reinforcement that we are really going in the right direction here with our recommendations. And I also want to share with you this next slide here. And again, right, more alignments between our recommendations and the HSO standard. And basically, the one that I want to highlight is the one on peer support. So we recommend to use peer support programs, right, to improve skills for self-management and provide updates on current SCI knowledge. And in the HSO standard 2.2.4, they talk about organizational leaders ensure teams have access to peer support services to support the person living with SCI throughout the SCI rehabilitation. Again, continuum of care. So we are talking about acute care, rehab, community, everything. So again, very much aligned with our recommendation. And again, there are other things that align well, but in the interest of time, I'll just skip them for now. But it's just, again, just to emphasize that our recommendations are very much aligned with the HSO standards, which the new SCI accreditation standards are based on. So how did we do this? Well, we really started the implementation just last year, 2025, because it took us all this time to really, understand the needs and also to come together, to build the consensus on what the recommendations, the themes and recommendations are. So we started the implementation just last year. I know that it will take more than 1 year to do the implementation. It will take way more than that, but we have had a very strong start. And that's because I think we have these embedded change champions in every team. And we have them at the Slave Lake Family Care Clinic, at the Chinook Regional Hospital and Post-Acute Rehab Program in Lethbridge, Spinal Cord Injury Alberta, Foothills Medical Center, and also Glenrose Rehab Hospital. They're just embedded there. And so these were people who were experts in their area with the contextual knowledge, the trust by their teams, and also they really could work with their teams to make sure that the recommendations can be built into their practices so that it's not just another research project that doesn't make sense to people's practice. We want to make sure that these changes will be built into people's practice so that they will be sustainable. And also, these change champions work together so that they are aligning their work together between the different sites and areas. And so over the last year, like I said, right, we have had a very strong start. We still have a lot more work to do, but I want to share with you that we've made most progress with person-centered care planning. I'm so proud that our teams have started this to really look at how the care plan can be done so that we engage people with SCI and their families. And also, so that the care plan can actually be owned by people with SCI even after they leave rehab. And so we've had some very strong work done. It's not finished, but I think that the teams have done some really great work there already. And then communication and collaboration also has been started with some very good discussions as to how to connect with our community partners. And so that's really important as well. And then for resource accessibility, like I said, that's been led by wonderful partners in SCI Alberta, and they also have done some incredible work there as well. And so I really want to thank all of the team partners for this strong work. But we need more work on these two items. I think for the focus on healing and recovery, I know that one is a complex one. It will take a lot more time. So I hope that we'll have the time and focus to work on that. And peer support and education. I think that we already have some strong work there, but I think that we need to actually think about that a lot more to see how we can do that across the care continuum. So, we've had a strong start, but I think that we still have lots of opportunities to do the implementation. So, what are the next steps for the concentric project? Well, I think that from meeting with people around the world, talking about the concentric project, like we presented in the international and national SCI meetings and got really good feedback from people. Then they told us what they do. Like I said, right, I learned from Sweden that they use peer support in a very different way, such a wonderful model. So I think that we should continue to learn about what other people do elsewhere as best practices and how we can then actually incorporate these best practices into our work as well. So that's one opportunity. And then in terms of full implementation of the concentric model and spread and scale beyond these pilot sites, I think that we need more funding to do this. So we're looking into funding support as we speak. And also, I think that, we just started this implementation last year. As I said, had no expectation that it would be done, within a year or two. It will take a lot longer. So I hope that we can continue with this work. And we also, have started to facilitate more, a relationship building and communication and connection with other SCI communities beyond Alberta. I'm talking about, other jurisdictions, other provinces, or even other countries who have expressed an interest in our work. And so we've had the privilege in talking with them. So hopefully we can do more work together because I think that this is a universal issue that many people are interested in. And then we're also looking at other future opportunities, like, when we talk about transitions in care here, right? We really are just focusing on rehab to the community. But as I showed you before, really transitions in care could also mean acute care to rehab and also from community, even back to the hospital, lots of different things. So there may be opportunities for us to look at the other transitions in care situations to see what we can do there as well. So I just want to summarize here by saying that the Concentric project is about improving the transitions in care from inpatient rehab to community through a community and evidence-based approach. And we are implementing evidence that we have created in real time. So that's really exciting. And secondly, the implementation of our concentric model will ensure compliance with some of the new SCI accreditation process using the HSO standards. I think that's so exciting. So would love to see how we can support more there. And the third one is that there are still opportunities to enhance our current practices together with partners from other jurisdictions and within Alberta to improve patients' transitions in care experiences and outcomes. So I just want to acknowledge our multiple amazing partners and funders who have made this work possible because really without the support, we couldn't have done it. And also, this project actually involved more than 100 partners from our SCI community across the province. So just want to thank all of you for this amazing support. And please feel free to connect with myself or Lei, our provincial coordinator, for this project. And would love to hear from you. Thank you.
Fantastic. Thank you so much, Chester, for that in-depth presentation. We have a couple questions. So I'll just set my timer here. We've got 10 minutes for questions. One that came up in the Q&A was, is there any chance that an SCI care navigator could be hired in these participating locations to help with transitions, support, accessing services, and continuity
Uh,
of care for people in the hospital?
Casey, that's an excellent question. So basically, again, we are talking about, right, in our recommendations and the themes and recommendations about the what. We didn't talk about the how. I think that if there are resources to have an SCI navigator to support their how, that would be amazing. I think that if we look at other jurisdictions, like in British Columbia, they just started the SCI Navigator program to support people's journey after they leave rehab. I think that's a wonderful service. But again, we have to find the resources. I think that, right, if we could have the resources, that could be a really wonderful thing to make sure that we really connect and collaborate, right, with our partners in the community and to have the navigator as the go-to person to support lots of the things that we are recommending there. Yeah.
Great. Chester, I have another question. Thank you for your presentation. The resource idea sounds great. Would the responsibility of putting the resources in a package be on each site, or would your project/team members create resource packages that could be tailored to patients by frontline staff?
Yeah, I think that it depends on what resources we're referring to. Because if they are resources such as, right, um, uh, 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 resources about things like funding, equipment, etc., I think that the team at SCI Alberta is already putting that together. And and so that will be available, through SCI Alberta and this project. So that's not a problem. But in terms of like a very site-based specific resources, we may have to like work with you to see what that may look like. I think that sometimes it may be like, okay, if you need to do this, what are the resource requirements? And so I think that sometimes it's about advocating for the right resources, right? To, inform policymakers and also management about what's needed. And I'm sure that, our project can support that without evidence there, right? And but sometimes, it may even be okay if you want to have these resources. Do you want to apply for a grant? Can I help you apply for that grant to actually generate the resources? I think that's different sites and locations, and partners can be very creative and will be happy to get creative with you to see how we can find additional resources.
Excellent. I do have a few more questions here for you, Chester. What barriers have you encountered in implementing standardized transition care plans across sites, and how can frontline clinicians help overcome them?
Yeah, I think that some of the people involved in the process may be in this session here, so they can chime in as well. But I know that in the processes that were started by the teams, let's say at the foothills and also at the Glen Rose, they have done amazing jobs to start that work. I think that basically, um, you know, it's just like, how do we actually do this? What's the approach? And also, we we left it up to the teams to determine what the approach may be. And sometimes, right, because we didn't, like I said before, we didn't want to tell people what to do, but we want them to kind of come up with their own solutions and in their own context, right? And sometimes it may be that, okay, if we want to get the input from people with lived experience with SCI and the families, what's the best way to do that? Is it to meet with them separately or to bring them to a meeting, or how is it done, right? So I think the teams have to explore those things because those are the things that they may not have done in the past. And it may require some initial investment in time by the teams to actually, you know, derive at the solutions, right? And so I think that in our current situation, time is not on the clinician side. And so it may be quite tricky for people to actually think, okay, let's really do this so that we can achieve this goal when they have like 10,000 other things that they have to achieve. And I think that's why um, the change champions were so useful in their role to support that. But I think that, you know, we sometimes it's really difficult because of the pressures when we have structural changes in our systems, when there are lots of pressures to achieve A, B, C, D, E. But I hope that, we can, despite all of the pressures, we can still kind of keep our target, in focus. And so we can still achieve that.
All right. And another one here. From the patient perspective, what parts of the transition process matter most? And what feedback have you heard directly from patients or families?
I want to say that actually, with the five themes and the 18 recommendations, they were all co-created with our persons with SCI and also family members. So those were the things that mattered to people. So I just want to emphasize that because those were not recommendations and themes that just came from the clinicians or researchers or healthcare, managers. They were actually largely coming from people with lived experience and the family members. So when we look at those themes and recommendations, those already represent what's important to people with SCI. Now, in terms of prioritization, I think that's a tough one because I also think that everyone's different because every person with SCI may have different transitions in care needs and may also have different priorities. So I would like to think that these are the themes and recommendations, but when the teams work with individuals with SCI, they need to really customize things, right, with the person to see what's actually the most important. So I'm not sure that I could really answer the question in terms of like prioritizing what's the most important for people there, though I just want to emphasize that all of those really were coming from people with SCI.
So thank you so much for answering that. We have just a few more minutes here for questions, and I have how about which patient groups are at the highest risk for poor transitions, and how can teams identify them before discharge?
You know, um, I think that the more um, issues we have to deal with, the more complex the transition will be and the highest risk. So I was reflecting, right? How can we determine that? One thing that our project has achieved was to design a tool called the My Experience Survey. It's actually a tool that evaluates the experiences of people with SCI um, during their transition. Curiously, despite the fact that we all know that transition is a big issue, there was never a tool that was validated and also that was, that had the psychometric properties measured for this purpose. So our project actually designed that tool. And so that tool can be applied before discharge, and people can actually evaluate, self-evaluate their experiences before discharge, and then work with their team to look at what may be risks, and then work with the team to overcome those risk factors. I think maybe that's one way to go about that. So that again, we're very person-centric, that we're really customizing that to everybody's own needs, right? I think that may be one way to go about that.
Fantastic. Thank you so much, Chester. Really appreciate you sharing again today. Um, it I know it's taken a long time to implement, but I'm still very hopeful. And because I am a spinal cord injury survivor myself, the change is needed, and we all, it's just change takes a long time. So I really
Right.
appreciate all the work you and your team and everyone across Alberta has really put into this. Thank you so
Thank you.
much.